Okay, good. So we have a session now on molecular tools to detect and characterize vivax infection. This was meant to be delivered by Dr. Kukeo, but he's had to run off somewhere. So Cindy is going to stand in for him, I think. Is that correct?
Yes.
Okay.
Actually, the topics changed a little bit. I'm not a lab doctor, I'm clinical. So I will explain a study where the team used genotyping and time to recurrence. So use lab data and clinical data to determine if the infection was a relapse or a new infection. Also, I think this morning, Sarah and also Jan went over the different molecular tools to try to distinguish relapse and new infection. So hopefully this will add to that. I want to go back to 15 years ago at 2010 along the Thailand-Myanmar border when we did 2 studies. And again, this is, I actually showed the Kaplan-Meier curve earlier this morning. But just to go over again, we did 2 studies. The first one was 2010 to 2012. We took 655 cases who were at least 6 months old. They were G6PD normal by the fluorescent spot test. And actually very similar inclusion criteria to the CDOT study. They could not have severe anemia, no blood transfusion in the last 3 months, and no pregnancy or women breastfeeding children. And we gave 3 different drug regimens. We gave artesunate monotherapy because it's short acting. We assume they'll have many, many relapses. We gave chloroquine, which is longer acting. We assumed that some of the relapse would be suppressed. And then we gave another group high dose primaquine with chloroquine. And then we followed them every month for a year. And this is the figure I showed you earlier, the Kaplan-Meier. It just looks a little bit different because of the colors. But again, just to remind you, this is artesunate, this is chloroquine, and when we give primaquine, recurrences drop a lot. But I just want to point out that we followed 1 year, but in fact, I want you to focus on this 4 months because most of the data we have now is at 4 months. So here we have a maybe about 15% recurrence rate after primaquine. After artesunate and chloroquine, it's more like 70 to 80% will have a recurrence. And just to point out again, at 6 months, we don't see much difference. Okay, and I showed you this earlier that actually, if we compare to the 1940s, the data does not look much different. This is a 4-month follow-up here. And these are soldiers that came back from malaria endemic areas. So we see that aminoglycinines, they work. Great. So this is the second study. And this was run from 2012 to 2014. And just keeping in mind that malaria transmission along the Thailand-Myanmar border at this time was decreasing a lot, drastically. So this study took 680 patients. We used the same inclusion criteria and exclusion criteria, but this time we gave everybody primaquine because we wanted to look at high-dose primaquine, but can we give high-dose primaquine over 14 days, or can we give it over 7 days, but we give double the dose? So now you might hear people talking about short course high-dose primaquine, the IMPROV trial. So the IMPROV trial was based on this trial we call BPD, best primaquine dose. So IMPROV used some of our protocol and the things that we did to modify their study. Again, we followed monthly for a year. And this is the Kaplan-Meier curve, except this is a cure rate, so it's upside down. But basically what you can see is that at 4 months, you have about 90% cure rate. But I'll just do it again, and then I'm going to put the study number 1, I'm going to put it on top, just upside down, you see. So then it's clear. So this is the artesunate chloroquine, and that primaquine arm is here, around here. So we see that. So then you can clearly see that the study number 1 and study number 2, when we give primaquine, they have about the same efficacy. Okay. Now, how do we know if a recurrence is relapse or reinfection? This is a figure from one of Nick White's papers. I've modified it, so I've changed the meaning of the figure a little bit. When a patient has had many vivax from many different mosquito bites over many months, they will have different genotypes in the liver. And you might have an infection this time with this genotype, but then when you have the recurrence later, if you have no primaquine, it might not be related. So your next infection, you do not know if it is a relapse or a new infection. Okay, that's what we're talking about this morning. And we also see in our data that actually sometimes a long time later, after 9 months, we actually do see an infection that probably is a relapse. So we might have, I think Nick probably would say, we probably have long latency in Southeast Asia. We just don't see it because we see the early relapses. Okay, so after we give primaquine, how do we know if it is relapse or new infection? And, right, if we give primaquine, is this a relapse or is it going to be a new infection? Do we have primaquine failure? And what complicates this is that inside the mosquito, if the mosquito has different parasites in the mosquito gut, the genotypes, they get all mixed. So what can happen is that in the mosquito, and I think Sarah was showing that this morning, in the mosquito, maybe they don't mix and you'll have the same genotype. Maybe the genes get all mixed, and when the mosquito bites the next person gets the mixed one. So that's the sibling, the brother or sister. Or it is unrelated. So it means that when you give primaquine and you get a recurrence, it could be a relapse, it could be a new infection, but even the relapses are not easy to know. Okay. I've simplified it. So Amy Taylor and James Watson, they're modelers. They took the 2 studies and they pooled all the data. And there were 1,400 recurrences over 1,000 years of follow-up. They did not, they sent the blood for genotyping. And this was before amplicon sequencing. And so we had whole blood stored from the CBC, leftover blood from the CBC. So they did, from the artesunate group, they only did 11 samples. The chloroquine group, 88 samples. And from these other groups, they did more. So they took 188 participants, and those 188 participants had 487 recurrences. And then they did the genotyping. So when they did the genotyping, they did microsatellite genotyping. They initially did three microsatellites, just 3 locations. And then they compared it, the paired sample, they compared the recurrence to the enrollment. And if the sample pairs were related, they did 6 more markers, so total of 9. Does that make sense to everybody? Okay. So it means if they were not related, it's clear they are not related. But if they were related by 3 microsatellite markers, they did extra 6 just to make sure they are really related. And this is a bit complex. I'll try to explain. So the orange one is no primaquine. The green one is primaquine. And this is time. Because these studies went to 12 months. And they did their modeling. And you can see here the recurrences that are early. This is a probability. This is the probability of 1. very high probability that this is related. So it's a relapse. No primaquine. So no primaquine, a lot of relapses, and almost all of them are before 4 months. And there's a few after a long time. Okay. Now, if you give primaquine, what is the probability? It is recurrence. Here you have a low probability, 0. And then you see here the early infections, early recurrences have a low probability to be related, to be a relapse. Okay. The line is they call credible interval. The line just means if we do it again, can we get the same answer? And so you see big, long intervals. So, this one maybe is less certain. This one has no credible interval. This is very certain, almost 100%. This is probably relapse, so maybe very related. So they did this figure, and you can see out here, when you get primaquine, these are all like very, very high, low probability, it is a relapse. 0 probability, this is relapse. So you see here one after 10 months. Here's some after 6 months. That's where they combined time and genotyping. Okay, this is another figure. So each line is one participant. Each line, one participant. So we have many participants. This one is also time. And you can see this participant, it's a enrollment, and then you have boom, 5, 6, 7 recurrences. We call that, they classify that as failure. So those had a high probability to be relapse. It means, oh, okay. I kind of yell, so if you hurt my ears, maybe turn the volume down. I speak very loud anyways. But you can see here that when you do not get primaquine, you have a lot of black triangles, and these are, we call, maybe you could say failure or related, relapse or recrudescence. These are not certain, and these are unrelated, the open triangles. And these are the ones who receive primaquine. One thing I want to point out here is one patient who did not get primaquine, and they have, looks like a relapse almost at 1 year later. And here's another one person who did get primaquine. It looks like something very related to the initial enrollment. But I mean, this was during a time of decreasing malaria transmission, so I don't know. They said diversity decreases, so I don't know. But this might have been a primaquine failure. So they did a lot of work to combine the genotyping between the paired samples and also with time. And they used that model to try to determine, is it relapse or is it new infection? So in study 1, the recurrence rate after chloroquine and primaquine was 18%. In study 2, if you gave chloroquine or DHA piperacin with primaquine, it was 12%. But when they combined the genotyping and time to recurrence, they were able to correct it. They removed all the unrelated recurrences, and when you only included the related ones, the relapse was only 3%. So we might say that primaquine efficacy, let me take a photo and I'll change it. Yeah, good, okay. Okay, here we go. So we can say that high-dose primaquine is 97% efficacious. In those studies, had 97% efficacy. But we know that to get this primaquine efficacy is very challenging and expensive. We have to have follow-up, we have to have repeated samples, we need a team that can collect the information. We also see that there are 2 late recurrences with high and certain probability that they were relapses, meaning that there might be long latency in Southeast Asia. And there were some limitations in this because we do not address submicroscopic parasitemia. It does address asymptomatic because we had active follow-up. The modeling assumed that the hypnozoite burden is constant. It assumed that transmission is constant. But actually, we see that malaria was decreasing at the time. When malaria is decreasing, you get less hypnozoites. So maybe the study is not relevant for today. It's just we have to be careful how we look at the results and interpret it properly. The study also did not look at recrudescence, so it did not look at the failure of chloroquine or DHA piperaquine. So this data cannot be applied where you have chloroquine resistance. So what next? CDOT is next, and we will plan to do next generation sequencing with actually the tools that were presented this morning. I mean, my question now in the context of this group is, should individual data be collected during operational work? Is it possible? Okay, I heard a yes. And if yes, how? Right? How do we get paired samples? How do we do it? Paired samples is a lot of work. And how does genotyping and surveillance, how does this information impact the clinical care of vivax and malaria elimination? Because just from my standpoint, if you have a vivax patient in front of you, you treat them. If you are concerned about their family and transmission, then, for example, in Laos, you might go to the family and test them and treat them. In another country, you might choose to do MDA. All of that is done whether or not you know it's done regardless if it is relapse or reinfection. So I'm not saying that we don't collect the data. I'm just wondering, how does this work impact clinical care and malaria elimination? And maybe we just need to make sure we're asking the right questions and interpreting data correctly and using it, having use case scenarios. So that ends the talk. Thank you.
Yes, thank you very much, Cindy. I mean, just to address that briefly, I think oftentimes, as you say, there are differences between clinical work and epidemiological work, and we just have, as you say, to formulate the right question that's appropriate for the technique we're using. Of course, if you have, if you have a patient who's sick, you treat them and you treat, etc. But that doesn't tell you anything about the large populations and vice versa. I think.
I mean, one of the things I have seen is where if you have, especially across borders, patient coming from the other country to this country, and then you say, well, that isn't our case. That's the other country. So I just think that we should be careful about the cross-border work and make sure that when we have the cases, they're treated regardless if they are from one country or another.
Yeah. I never thought that wasn't the case, but yeah, okay. Any questions for Cindy on this presentation? Yes, Dr. Sid.
I had no question, but I just would like to know the next step. Do you have ability to do that? How maximum of relapse for each infection for Mekong country region compared to other?
I'm sorry, can you ask that one more time, Dr.
The
Sid?
maximum of relapse of each individual.
Yes, okay. So in the artesunate arm, where it's really like placebo, we had, especially children, relapses 9, 10 times. And, really, I have to be honest, the ethics of this study, if we do the same study today, it would not be ethical.
Yeah.
But at that time, it's, something different. So in some children especially, we see up to, more than 10. At 10, we give primaquine because we didn't know much about it. And then But I would say when I looked at the data overall, it's about 5 overall.
For GMF country.
Yes, for this. Well, I would say then at SMRU, because the study's only at SMRU. But that's just an observation. I think you need a modeler who can do much better work on that.
Other questions? Yes, John? Oh, sorry. But no, please go ahead. Sorry, I haven't seen you around.
No worries. Thank you. That was a great presentation. So you're saying it's quite complex and expensive. Do you think you can use that, like the study results, to kind of summarize the time frame based on what you're seeing in the region, the time frame for a reinfection versus a relapse given the treatment? So thinking from the NMCP perspective, you can say, just looking at surveillance data, not the genotype data, can that inform? Can your results inform that time frame?
I would say if you didn't give primaquine, it can be fairly informative, because when you do not give primaquine, the relapses come fairly regularly.
Before 4 months?
Yes. 90% of the recurrences occur within 4 months. But when you give primaquine, I think it's much more difficult to say. And also, I think as transmission goes down, this comes out of a paper from Nick White, that as transmission goes down, you might even see a lengthening of the latency. So there are a lot of things as vivax epidemiology changes, we might not be able to use prior data or prior knowledge as we go forward. I think that's something that's been really interesting for me.
Yeah, to your last question there, somebody in the room said yes. I just want to mention that I know Lao's been thinking about collecting the new ID number that everyone's going to get and putting that in with the epi data. But just wondering about for other countries, I agree with your assessment. The question, I guess, is that like whether it's relapse or reinfection, how does that change your actual implementation on the ground, right? And I guess it could be a question of, is it something easy to collect, or is it something that's going to be quite burdensome? So I think for Lao, I guess they've made they're hoping to be able to get that as soon as that ID number is in place soon, to get that in with the epi data. But just wondering if other countries had ideas about how easy or hard that might be in future, and what impact you might see on your program from that.
What difference does it make to the treatment to know?
Probably. I mean, I really think that surveillance is important. It's important to know what's circulating. It's important to know where things are coming from at a population level. It might be harder to interpret the information for individuals, but at the same, it's very important. But from a clinical perspective or even operational perspective, I don't know. I don't know. Maybe that's what Sarah had asked that question this morning. How can, what do the NMCPs think about how the genetic data could help them?
Just
yes,
a
Rita.
quick comment to that. It could be useful in case we see a lot of relapses, then we know that maybe the follow-up is not complete. People may be saying they're taking all the medicine, but we don't have the right data, or that we need to switch from, we're currently on the low dose PQ, that it's really important to switch to the high dose PQ. So I think it could be useful, maybe not for that individual case, but would be useful for the country to know as a whole.